Welcome to this lecture about clinical examination of ER orthopedic patient. In this video, we will answer some questions. What are the classifications of the trauma patients? How may the trauma patient come into the ER? What are the symptoms or the main complaints? How do we examine the trauma patient? What are the causes of trauma? How to study the case of ER patient by doing inspection, palpation, and special tests. Finally, how to manage the case of ER trauma patient as GP doctor. Welcome again. When we talk about trauma patient, we may feel some fear, but indeed, we shouldn't hesitate. We should always start by following the rules, by doing the ABCs for the patient to save their life. Then we can focus on the site of trauma. The main cause of having classification for trauma patients is to distinguish the urgent case from that cases can be delayed. And this is very important when you have too many patients in ER. In some specific situations, like earthquakes or explosions, and we have too many ways to classify ER patients. The most popular classification depends on colors, like green, orange, red, and black, to distinguish among minor, delayed, immediate, and dead cases. In statements of disasters, we should have a team of expert staff at the entrance of ER to classify every case before entering the ER. How could the patient come into the ER? If the site of trauma is in the upper limbs or upper part of the body, the patient may walk normally. But in the case of traumatized lower limb, the patient may come supported by crutches or transported by wheelchair or stretcher. What are the symptoms and the complaints that the trauma patient usually complains about? The trauma patient may complain about pain, cut and bleeding, pallor, limping, numbness, or disability. How should we examine the trauma patient in ER? First of all, we should ask and ask. We should ask about the cause of the trauma, the mechanism, or the duration or the lost time between having a trauma and entering the ER. And after asking, we should examine the patient by doing the following steps. The inspection, which means to see, the palpation, which means to feel, and finally to do the special tests. It's very important to ask about the cause of trauma. That will give us more ability to suspect what kind of injuries may the patient have. The most popular causes of trauma are traffic accidents, and here we distinguish between intra and extra vehicle accidents. Falling downstairs or falling during normal life activities also could be causes of trauma. Explosions and gunshots and other military works during war are very important causes of trauma. Sprains, strains, muscular or tendinous tears are very popular in sport medicine. Fighting, hitting, kicking, violence, and injuries during working may also cause many kinds of trauma. By the way, what are the differences between direct and indirect trauma? To answer this question, it's better to explain these by discussing these examples. The first example, and in the case of falling downstairs, shoulder dislocation is caused by indirect trauma, as the contact point with the ground is far from the shoulder. And in the same example, wrist fractures or dislocations are caused by direct trauma, as they are at the contact point with the ground. The second example to explain the differences between direct and indirect trauma is a very popular case named dashboard injury, which happens usually when the dashboard of the car hits the knee during intra-vehicle accident. So, the patellar fractures are usually caused by direct trauma as it locates in the contact point with the dashboard, whereas the fractures or dislocations in the femoral shaft or hip joint are usually caused by indirect trauma, by the forces that go through them far from the contact point at the dashboard and the knee. When we talk about the pain, we always remember the rule of Socrates, which is very important to be followed when we study the pain in any organ. And according to this rule, we should ask about the site of pain and where does it locate? In the hand, the knee, the femur, the shoulder, or anywhere. Then we should ask about the onset of the pain. Did it start suddenly or gradually? After direct or indirect trauma or without any trauma? Then we should ask about the character of pain. Is it itching or burning or anything else? After that, we should ask about the radiation of the pain. Does it radiate or locates in the same site? This question is very important in the case of C or L spine trauma to ask about the radical pain. Swelling, fever, lack of range of motion, clicking, instability, and other associations also we should ask about. When we ask about the timing of the pain, we should distinguish the mechanical pain, which comes during movements and walking, from the inflammatory pain, which comes usually during the rest time or sleeping. The exacerbating and relieving factors, like medication, especially the painkillers, and ice and head bags, also should be known. Finally, we should ask about the severity of the pain. Is it mild, moderate, or severe? To suspect the histological damage after trauma. And to keep this rule in mind, don't forget about the pain of our great philosopher, Socrates. Is it important to ask about the duration or the lost time between the accident and coming into ER? Of course, it's very important because if we know the duration, we can suspect the ability to have infarction or infection in some parts or some extremities. And we also can figure out the amount of blood lost during the lost time between the accident and coming into ER. In orthopedic clinical examination, we don't have auscultation indeed, but we have inspection, palpation, and too many special tests. As medical students and GPs in ER, we should know about inspection and palpation. Inspection means to see by eyes, whereas the palpation means to feel by your hands or fingers. What could we see in the case of ER orthopedic patient? We may see cut or wound, burns caused by hot objects, scars of previous surgical interventions or wounds, ecchymosis caused by ligamentous injuries or sprains. We may see also swelling, joint effusion, and we can see some changes in color, like the pallor, which is usually caused by arterial occlusion, or the rubber, which is usually caused by venous occlusions. Regarding the upper and lower limbs, we can know the discrepancy or asymmetry in length. And also we can note the abnormal gait or limping. And we can also note some skin lesions like sclerosis, psoriasis, and vascular abnormalities that may refer to the presence of systematic disease like systemic lupus erythematosus (SLE) or rheumatoid arthritis that may need some special concerns in treatments. Regarding the inspection, also we can see some typical positions that determine the suspected differential diagnosis, like this shape that refers to right shoulder dislocation. The position of flexed hip and flexed knee with shortening and internal rotation of the lower limb refers usually to posterior dislocation of the hip, as we see in the right lower limb here. This typical photo for a crying kid who avoids moving his left upper limb after falling down or pulling his left forearm is usually typical for left bullet elbow. Externally rotated left lower limb in this photo is typical for intracapsular femoral neck fracture. When we see a patient like this, holding his forearm with this abnormal shape in the right elbow, the main differential diagnosis should be posterior dislocation of the right elbow. The dinner fork shape at the distal forearm is typical for Colles fracture at the distal part of the radius. And this malformation at the right shoulder, which is usually called the piano finger shape, is usually typical for the AC joint dislocation. Mallet finger and disability to fully extend the distal interphalangeal joint in this middle finger is usually typical for a virgin fracture or disruption at the inserting point of the extensor tendon. In orthopedic clinical examination, we should always use our hands and fingers to feel, palpate, and to apply pressure to determine the sites of tenderness. And for medical students, we should always distinguish between the pain, which is a symptom that the patient usually explains about, and the tenderness, which is a sign that we promote by applying pressure. And this part of clinical examination is called the palpation. We palpate the arterial pulse, the edema or masses. We usually use the finger to process and to distinguish between cholestatic and inflammatory edema. We could feel dryness, moisture, coldness, or local fever. One of the most important rules in ER that we usually use to suspect the ability of having infarction caused by arterial occlusion or arterial cut is the rule of 6 P's. In the case of having infarction, we usually have these 6 P's: pain, paralysis, pulseless, paresthesia, pallor, and perishingly cold. The special orthopedic tests like Leishman, Nair, Hawkins, Drawers, etc. should be done usually by the specialist, and they will be explained in another lectures for orthopedic residents and master students. And as GB in ER, we should ask for lab tests, X-rays, ultrasound, CT scan, and we may ask for MRI after orthopedic consultant or specialist consultation. Finally, here is the way that we usually use to ask for orthopedic consultation as GB doctors.